Just going to give it another minute and we'll start momentarily. It's very fun seeing all the names coming across my computer screen. Welcome, everyone. Okay, I think we have many folks. There'll be a few others that will join us over the next little bit, but we have lots of great things for this evening, so I think let's get started. So welcome, bienvenue. I'm Shawn O'Hearn and Director of Global Health at Dalhousie University in Halifax, Nova Scotia. And I'd like to begin by acknowledging that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. We strive for respectful relationships with all the people of this region as we search for collective healing and true reconciliation as we honor this beautiful land together. I would also like to acknowledge that you are joining us today from many places, near and far, and acknowledge the traditional owners and caretakers of those lands. So let's be honest, 2020, it's been a tough year. It's difficult, and I think we need to take some time to acknowledge that, to respect it. And while it's been difficult, it's also created a space for reflection and opportunities for conversations like the one we were having today. I want to take a moment just to reflect on the pandemic. In some ways, the pandemic will make global health easier, and in other ways, it's going to make global health much harder. On the positive side, we no longer need to demonstrate that the world is interlinked. Everyone now understands health can be put at risk by things on the other side of the world, and that health is interdependent. This is an argument that we have, in the global health community, have talked about for years. We also no longer need to justify why global solidarity and international collaboration is fundamental to keeping the world healthy and safe. We don't need to make a case for investing in health. Every country has learned the hard lesson to destroy the local and the global economy. Investing in health is investing in the economy, and the pandemic has underscored the critical importance of determinants of health and the need for social investments. Yet global health is dominated by experts and institutions, predominantly in high-income countries. Global health is failing in equity, reciprocity, and bidirectional partnerships. The pandemic is becoming the new excuse for nationalism, xenophobia, and racism. These are not new trends, but they're exacerbated and highlighted and exposed to a much larger audience in these unprecedented times. We must recognize and acknowledge that global health is more than fighting one pandemic or one epidemic after another. We must use a health systems lens guided by the determinants of health and health equity. I came across a quote that was in the April 2020 BMJ article by Dr. Kickbush, Leon, and Buta that I thought was very fitting for today and wanted to share it with us. COVID-19 has taught us that health is the basis of wealth, that global health is no longer defined by Western nations and must also be guided by Africa and Asia, and that international solidarity is an essential response and a superior approach to isolationism. We may emerge from this with a healthier respect for the environment and our common humanity. End of quote. So, my job this evening isn't to keep talking, but it is to moderate. In the process, I wanted to share the foundation of where the planning for this event emerged. And it did through the conversations and discussions at Dalhousie's Global Health Office, as well as through the Canadian Society for International Health and the Canadian Coalition for Global Health Research. This, I would argue, is such an important time for the direction and the future of global health. For many of you, for many of us, we have, and I will put in quotations, quietly been pushing behind the scenes to grow an inclusive global health community. This is the start of this public conversation. So back to my job. First, I really want to thank the team who's been instrumental in getting us to this virtual time together. In particular, Angela Day, who has worked with the panelists and our IT experts to bring us this enriching discussion. This work and all global health work is done collaboratively, and I'm thrilled that we are here today. And I have the pleasure of introducing our esteemed panel, who will be speaking about global health post-2020 and examining issues of decolonization, the impact of the pandemic, health for all, and authentic collaborations, amongst other issues and areas. Our panel will help us examine the current and future roadmap for global health by sharing their expertise and examples that will guide our work. So I'm going to introduce one panelist at a time, and each panelist will take about 10 minutes. This will be followed by a question and answer period. While you're listening to the presentations, please feel free to use the chat function to start putting in your questions, and we're going to do our best to document them and to get them to the panelists at the end. A couple of housekeeping items. First, we encourage you to turn off your cameras, not because we don't want to see your lovely faces and engage with you beyond through this technology world, but our technology won't accommodate over 120 of you that are here today for this event. So we will at some point be able to come together and be face to face, but not this evening. So the second housekeeping is that the event is being recorded, and we will have a link to share at a later date with you. So now to the good stuff. We're going to begin with our first panelist. Dr. Renzo Gento is the Chief Planetary Doctor of Public Health Lab, which is a global think and do tank for advancing the health of both people and the planet. He's also an Associate Professor of the Practice of Global Public Health and the of the Global Health Program of the St. Luke's Medical Center College of Medicine in the Philippines. He completed his public health training at Harvard and his medical degree from the University of the Philippines. An Obama Foundation Asia Pacific leader and Aspen Institute New Voices Fellow, Dr. Renzo is also a commissioner on the Lancet Chatham House Commission on improving population health post-COVID-19. He's a strong supporter for the field of planetary health and for decolonizing the field of global health. And we're very fortunate that he's here this morning for him. So welcome, Dr. Renzo. I will hand the virtual floor to you now.
Thank you very much, Shauna. Can you hear me clearly?
I can, yes. Wonderful.
Okay, so I hope you can see now my screen. Again, good morning from Manila. It's 6:30 a.m. the following day, actually, here. And again, it's a deep privilege to be part of this conversation with the Dalhousie community. And, you know, you mentioned, Shauna, about the COVID-19 highlighting the interconnectedness and interdependence that we have. And I think this Zoominization of our convenings in global health is one proof of that. So for the next 10 minutes, I'm here to give a brief overview about this emerging discourse around decolonizing global health, which I've been a part of for the past several years. And Shauna mentioned a while ago PH Lab. So it's actually PH Lab, and you got the first PH right, that's public health. But the second PH is planetary health, which I will shortly discuss towards the end of my talk. And the third PH is actually the Philippines. So PH is the nickname of my country. And let me begin by giving you some overview about where I'm coming from, why I'm deeply involved and invested in this discussion around decolonizing. The Philippines is a country that has experienced multiple, not just one, but multiple colonial experiences. As we always joke around here, we've lived for 300 years inside a convent with the Spanish who brought Catholicism to our country. The Philippines is the only Catholic country in Asia. And we also live for 50 years inside Hollywood, and that pertains to 5 decades under American rule after Spain has actually sold the Philippines to the US for $20 million. And finally, we're still all waiting for the results of the elections that our former colonizer has just conducted. And in 2021, next year, the Philippines is actually commemorating, not celebrating, its 500th or the 500th anniversary of the arrival of Spain and Christianity in the Philippines. If you notice, Philippines is actually named after Philip II of Spain. So if you're thinking about coloniality and nationalism and countries, we are a country that is actually named after a colonizer. And the history of the Philippines is is actually filled with stories that show the connection between colonialism and medicine. So as you can see here, one of these stories, and I'll just briefly share it with you. I encourage you to look into it. In the early 1800s, there was this expedition from Spain to the Philippines via Latin America, where they brought around 40 young boys, all serving as a reservoir for the newly discovered smallpox vaccine. Remember, Edward Jenner discovered the smallpox vaccine. They put the vaccine or the anti the vaccine into the kids, and they were all sent to the other side of the world so that they can vaccinate Filipinos as well as the Spaniards who are staying in the Philippines. It's called the Balmis expedition. And I would always say that the King of Spain during that time, who was the architect behind this project, could be the first Bill Gates in contemporary global health. And again, this is an example of how colonialism enabled the diffusion of medical innovations coming from the West. And then here, as you can see, I would like to invite you to take a look into these two books that look at the nexus of colonialism and medicine. Warwick Anderson, who now teaches in Sydney, wrote his dissertation about the role of American colonialism in not just introducing Western medicine to the Philippines, but also in using medicine as part of what they call civilizing project. And then the other book by Catherine Sinisa Choi, Filipino-American historian from University of California, Berkeley, wrote about the colonial roots of health workforce migration. As you know, Filipino nurses and doctors are scattered around the world, including in Canada. In fact, one of our Filipino nurses is listening right now in this webinar. And that is not a contemporary phenomenon. It has very deep colonial roots. Again, part of this civilizing project, sending Filipino health workers around the world. And then another interesting trivia about the Philippines and its, and the links between colonialism and medicine is that our national hero is a physician, Dr. Jose Rizal. He studied in Madrid, studied in Europe, medicine and ophthalmology. And during that time, that was the time when he got exposed to the liberal democracies of Europe. And he realized, if these countries can be free countries, why can't the Philippines as well? And so he studying medicine to also write 2 novels that led to the Philippine Revolution. And unfortunately, when he returned to the Philippines, he got executed by the Spaniards. But that again ushered, the revolution of the late 19th century. And as you can see there, he is a very close friend of Rudolf Virchow, who I know is very familiar to you. Virchow's nodes, Virchow's triad, a lot of the things that we study in medicine have been named after Virchow. He is also the father of social medicine, and he is the one who said that medicine is politics, or politics rather, is medicine on a grand scale. So very strong links between politics, medicine, and colonialism. And so 100 years later, I saw myself being involved in this emerging conversation around decolonizing global health. It started with a hashtag. As you can see, this is my first ever tweet to use the hashtag decolonize global health. Obviously, decolonizing global health is not a new thing, but now it has been a conversation in social media, on Twitter, and now it seems that it's becoming its own movement as well. And thankfully, we have Dalhousie organizing this conversation. So it seems that that this virus of decolonizing global health has reached your side of the world. And as I said, I'm just giving you an overview. Over the past 2 years, we've seen an avalanche of articles about this. I will encourage you to also start thinking about how does decolonizing global health, what does it mean for the Dalhousie global health community to decolonize global health? What can you offer? What are the issues that you need to address if you truly want to decolonize? And Dalhousie now joins this army of universities around the world that has already organized the Colonizing Global Health Conference, established postdoctoral fellowships in the decoloniality of global health, so on and so forth. But one thing is common. These universities, including yours, are all located in North America and Europe. And now the challenge is how to bring the decolonized global health conversation to other parts of the world, especially to Asia, Africa, and Latin America, where former colonies are located. And then, of course, Shauna gave a very wonderful introduction about the COVID moment where we're in. And here you can see that a lot of articles recently have also started raising this issue. Are we perpetuating global health's coloniality in our responses to COVID-19? From French doctors insinuating that Africans should be used as guinea pigs for the new COVID vaccine, to these prescriptions from the North. This is what should be done in places like Africa or Asia, when in fact Asian countries have shown the world how to address COVID-19, the epidemic, and Africa is now, it seems to be now enjoying the African advantage, as we know that they have very little cases and deaths related to COVID-19. And so many, realizations we are seeing now in the age of COVID. But again, these are not new issues. And, I'll not go into detail. I'm just showing to you the panoply of thinking around decolonizing global health, in research, how being articles about the Global South with no Global South authors, or global health journals with representation only from Europe and North America, or global health exchange programs that are truly not exchange programs, because while our friends from the North are able to participate in these immersions, volunteerism activities in Africa and Asia, there are more difficulties encountered by students from Africa and Asia to go to the North, for instance, because of visa denials that the northern countries impose on these students. And even in global health leadership, we are seeing that leadership is very much skewed towards the North. Most of the institutions are based in the North. Most of the leaders are old white male coming from the North. And these organizations are designed to address problems in the developing world. So how can we address these imbalances these power asymmetries in global health leadership. And as you can see here, enough of panels that are called Manels, all male panels, Hicanels, high income country panels, and one else, white panels in the era of decolonizing global health and COVID. So I'm glad to be part of this panel that is very diverse, with women, with people of color, with people from different countries. This should be the norm. And then also important to also acknowledge in this decolonizing global health discourse is that there are new colonizers that are emerging, also called neo-colonizers, and they are emerging in different forms. They are corporations like big pharma, big food. They are philanthropic organizations, the Gates Foundation, of course, the much older Rockefeller Foundation, bilateral agencies like USAID, or SIDA of Sweden and SIDA of Canada, and also universities, even like some of the logos included in this slide. And so to wrap up my brief presentation, I know it's so hard to squeeze in a lot within 10 minutes, but this is more of an inspiration, an overview, and a provocation. Uh, Words of caution: we need to make sure that in the process of decolonizing, we don't end up being neo-colonizers ourselves. And I am very cognizant, not just of my, positionality, as a brown-skinned, Asian, young scholar, activist, practitioner from the Philippines, but also, as mentioned already by Shauna a while ago, I had the blessing of a wonderful education from Harvard. The experience of being interconnected with colleagues from around the world, from north to south, and so we are all an interplay of privileges and disadvantages, and we need to make sure that we acknowledge these positions, and we need to face these decolonizing discussions with courage and with a sense of mission, with power as comes great responsibility. We need to go beyond the cosmetic. Of course, we want more people of color in advisory boards, in editorial boards, in journal article authorships, but we need to look into what are the colonial roots that underpin all these superficial manifestations of colonialism, the power imbalances, the lack of diversity and representation. And then finally, I think this is an invitation to planetary health, a new field that has been recently introduced, which encourages us to go from an egological approach to a more ecological approach, because I think that environmental racism, degradation, climate change, these are the highest forms of colonialism, because it's colonialism of humanity over nature. And so let's start exploring the colonizing potential of planetary health. And I think we have lots to learn from our indigenous communities. We invoked, our ancestors a while ago during the opening, and we need to listen to them more as we try to reshape the future of global health. And so there are so many things that we can do, from self-reflection, forming these kinds of global alliances, and I hope Dalhousie will be part of this new coalition that we're building. Critical global health education, and global health education that is not depoliticized and ahistorical. And ultimately, we need to tackle the systematic roots and listen to new alternative voices that are usually not represented around the table. So together, let's advance the health of people and planet, and we look forward to a more decolonized global health post-2020. Thank you again, and looking forward to our conversation.
Thank you very, very much. Sorry about that. Does everybody hear me again? I got booted out. I was so overwhelmed, Dr. Renzo. There was so many wonderful messages. I know a lot of what you were sharing are part of the conversations we've been having here at Dalhousie. So I look forward to the discussions afterwards. Thank you very much for that very engaging and thoughtful presentation. I'm going to move to Dr. Lisa Foreman, who is a Tier 2 Canada Research Chair in Human Rights and Global Health Equity, as well as an Associate Professor at the Dalla Lana School of Public Health at the University of Toronto. She's an international human rights law scholar whose research explores how the right to health may contribute to advancing health equity, including access to medicines, universal health coverage, and also including COVID-19. She's a member of the Global Health Law Consortium and the Ontario COVID-19 Health System Response Bioethics Table. Dr. Foreman qualified as an attorney of the High Court of South Africa, where she completed her law training. Also did graduate studies in the Master's in Human Rights from Columbia University and a doctor from University of Toronto's Faculty of Law. We're very fortunate to have you here today, Dr. Foreman, who will share some of her work around global health equity, particularly in the time of COVID-19 and these American elections. Am I still helping with slides?
Yes, please, please. Thank you.
No
okay.
Make sure I use. Where did your slides go? They were right here. Sorry.
No problem. So while you're teeing that up, maybe I'll get started and just thank you, Shauna, so much for the invitation to participate in this fantastic panel. It's such a fantastic invitation to think about how we should move towards more equitable global health futures. And, you know, when Shauna approached me about this, I proposed talking about global health equity in the time of COVID and trying not just to give it a catchy hook at an opportune time, but because these broader contexts really matter for global health equity. And even if we are hopefully moving into a post-Trump era, this presidency reflects broader trends that have real implications for global health. And all of this is happening at a time when we know how the pressure that COVID is placing on our institutions and our systems, and magnifying and really exposing the weaknesses and the faults in these systems, and really reinforcing the need to change those systems, including the academic enterprise of global health itself. And Renzo, thank you so much for that incredible presentation. There's so much of what you said in there that I know I'm going to be thinking about for quite some time. So what I'm going to do in my short time is really sketch the bigger political economic context for health equity. I'll start by talking about some of the changing ways in which we speak about and understand global health equity and how those changes are playing out in policy initiatives like universal health coverage. And then turn to consider how those trends are intersecting with some larger economic and political trends. And then finally turn to consider how these are playing out around COVID and how this might be, what the implications might be for global health equity. Do so from the lens that I bring to this research and practice and education and scholarship as a legal scholar, whose work focuses on international human rights law and the right to health. There's a very specific method of concretizing health equity in law and policy, even though this is not at all the focus of my talk today. So I'm going to start by just really kind of stepping a little bit back in terms and talking about some of the ways in which we've started how we speak about global health equity. You know, when I started my graduate research in the early 2000s, this area was still called international health. And that change really came in the last 10, 15 years. And international health was really something fairly different in the sense that it was characterized in theory and practice as northern researchers researching and responding to ill health in the global south, and which focused fairly narrowly on technical fixes and vertical programs to address infectious disease. And so, Shauna, you can change the slide to the first slide. So I think a really big change, a game changer for the paradigm of global health came with this report from the WHO in 2008 from the Commission on the Social Determinants of Health. And I'd suggest that this report made really significant, subtle and significant shifts in how we talk about global health. Firstly, by reframing health and global health as really in needing to go beyond discrete health issues in health systems towards the far bigger picture of the social determinants of health, something that it termed as the conditions in which people live, work, and age, and the systems put in place to deal with illness, and the political, social, and economic forces which shape those conditions and systems. So the report, with the focus on the social determinants of health, made it really clear that we need a far bigger picture in global health if we're really going to address global health issues. And that if we cared about disparities in health, we had to care about them everywhere, not just across the world, but in our own backyards. Now, the second really important thing that the report did was to reframe the imperative to address those inequities as a question not of philanthropy or charity, but a question of social justice and of human rights. And it famously frames the reduction of health inequity as an ethical imperative and argues that social injustice was killing people on a grand scale. And Renzo quotes Rudolf Virchow, the father of social medicine, his famous quote that medicine is politics writ large, and I think this framing really reached back to this. So I'm being purposefully ahistorical because we have 10 minutes. I'll just acknowledge that obviously there's a much longer history for health equity and human rights, and back to the I'll start in the 40s with the creation of the UN and the WHO, and then the things that were happening in the 70s, like the Declaration of Alma Ata and the new International Economic Order, and then the AIDS treatment campaigns in the early to mid thousands. But whatever came before and enabled this frame in this report, and whatever its flaws, I think the report has fundamentally shaped how we talk about global health equity today. So next slide. So I think you can see some of this change and this impact and influence in the way that we speak about health equity. This is last week's report on the state of public health in Canada, which the Chief Public Health Officer of Canada issued. And it takes an equity approach to COVID-19, which is explicitly rooted in the conceptual framework of the Commission on the Social Determinants of Health, both recognizing on the one hand that the structural determinants of health drive health inequities because of how they shape the distribution of power, money, resources in society, and shape people's control over their health, and also by focusing on injustices like stigma and discrimination as key drivers of health equity. And I think you see some of this framing, remnants of this framing in global health policy initiatives like the Sustainable Development Goals that were finalized in 2015. Next slide, please. So the SDGs there's a wide range, a very significant range of goals on a range of issues. Now, the health goal in Sustainable Development Goal 3 is quite different to the Millennium Development Goals which preceded it in terms of having a wider range, a focus on a wider range of issues, but also by including this system-wide goal, this health system-wide goal of achieving universal health coverage, which focuses attention on broadening access to essential health services and reducing catastrophic health expenditures, and which has received an incredible amount of attention in the global health fields, far beyond what you would have assumed it would receive as, SDG goal 9 of, 8 of 9 health goals. And whatever the shortcomings of the way that universal health coverage has been conceived and defined and implemented, for those of us who are in the right to health community and the health and human rights community, we felt that it came closer to reflecting the human rights imperatives of universality, equity, and affordability in healthcare than many other contemporary global health policies. But if you've been paying attention to what's been happening around universal health coverage around the world, you know that progress had been very uneven and quite disappointing even before COVID. Next slide, please. So UN reports have been showing that there's been a stagnant and regressing health system financing, continuous increases in catastrophic health expenditures, and major gaps in essential health services. And before COVID even, the World Health Organization was saying that if these trends were to continue, the world was likely to fall far short of the target of universal health coverage for all. Now, I think bringing a health equity lens to some of these larger trends tells us partly why this is the case. Next slide, please. So the first is the longer-standing political and economic policies that promote the commodification of healthcare as not just fiscally responsible, but the price of entry for low and middle-income countries into the global economy, and which favor reduced health and social spending and have ratcheted income inequality within and between countries and worsened health and social problems along the income inequality gradient. And these are impacts that worsened with austerity policies that entrenched after the 2008 financial crisis, where we saw major cuts to public expenditures, including on health, in high-income and low-income countries alike. And these have not just hampered progress on universal health coverage, but they've made effective responses to COVID far harder. Next slide, please. So the other significant trend, which had been happening long before Trump, is a consistent global trend of democratic retreat, consistently happening. Freedom House has been documenting this retreat for over 14 years. And the indication is that we're now at a point where, for the first time since the Second World War, where more countries are autocratizing, become less free, than democratizing, becoming more free. And certainly Trump's election has only added fuel to this trend. Having the US back away entirely from any semblance of concern for democratic norms, for human rights, for international law, for global solidarity has been incredibly destructive. Not just directly, as in the US withdrawing from the World Health Organization, but indirectly because of the outsized cultural, political influence that America has globally. And I think this longer trend suggests that irrespective of the outcomes of the US election, this presidency, Trump's presidency, is likely to only fuel this trend further. And these trends have been just a perfect storm for health inequity. Next slide. A recent study found that autocratizing countries made less progress on expanding health services under universal health coverage, and they had higher out-of-pocket spending, with the study scholars theorizing that it was at least partly because of how democratic erosion reduced the willingness and capacity of governments to respond to the health needs of citizens. And we've seen these trends converge around COVID in just incredibly destructive ways, where populist nationalism has not just been opposed to law and rights and the media, but also to science and facts, as Trump and Bolsonaro's approaches to COVID have illustrated, so that COVID responses in those countries haven't simply deprioritized standard public health responses like contact tracing, testing and care, but actually actively discouraged compliance with things like social distancing, quarantine, mask wearing, contributing to the kind of failed COVID responses we're seeing there. Next slide, please. So this is a screenshot I took of the World Health Organization dashboard on COVID earlier today. And it shows that the highest rates of COVID infection and COVID deaths are in the US, India, Brazil, and Russia. Those countries with highly politicized responses to COVID, prominent instances of failed leadership on COVID, and significant trends of democratic retreat. And COVID comes into this mix in ways that amplifies and exposes the weaknesses and unfairnesses of our political and economic systems more broadly. And we're seeing that specifically and significantly in the way that infection and death is increasing, not just along the income gradient, but is amplified by factors like race, disability, and gender. Next slide, please. So in Toronto, over 80% of COVID infections are in racialized populations, who only make up 50% of Toronto's population. And we're seeing similar trends in England, where Black people are 4 times more likely to die from COVID, And in America, where racialized groups are more likely to get infected, be hospitalized, and die from COVID. And these disparities are coming because of how social and political determinants of health are intersecting with social biases to increase exposures and increase the severity, the prevalence of underlying medical conditions, and decrease access to healthcare. And it's surely not a coincidence that in both Canada and the UK, there have been tremendous controversies both over gathering and disclosing data like this. So I'll close just, the final slide. Just some thoughts about the implications of what this means. I think what it lets us know is that the political and economic determinants of health matter. COVID's hit harder where health care is underfunded and inaccessible, and where political leadership has been poor and unwilling to consider evidence and science. And it reinforces how important human rights are as guides to fairer COVID policies and as tools to challenge those policies when they disproportionately and unjustifiably cause harm. And some of the most significant instances of this are coming out of Malawi and Kenya and Uganda, where activists and advocates and lawyers are using legal standards and laws to challenge COVID policies that are needlessly restrictive. But I think the other implication is that universal healthcare and health human rights protections haven't prevented the differential impacts of COVID along races of race, income, disability, and gender, partly because of how those biases are embedded in our social and economic system. So if we are to advance towards global health equity, I think the implication is that we're not going to get there unless we respond to the way that those biases that drive inequities are not just in our broader institutions and policies, but in our academic institutions where we live, work, and grow. I'll end there.
Thank you, Lisa. There we go. Thank you very much. I think going through the history is important to get us on the page of showing where international health has merged into global health and how that impacts the various intersections of determinants of health as well. So thank you for that very rich discussion. We're going to move now to Dr. Yipeng Ji, who I've known for a few years now, but I'll just give a little bit of background so we all know who you are. So Dr. Yipeng is a Chinese-Canadian first-generation immigrant who grew up in Waterloo. He's a resident in public health and preventative medicine in Ottawa, where he also did his medical training. He is Canada's official youth delegate to the World Health Assembly and the Pan American Health Organization's Directing Council. Dr. Yipeng is interested in tackling health and social inequities through addressing the social and broader determinants of health. He was the Vice President of Government Affairs for the Canadian Federation of Medical Students and served on a variety of boards, including the Canadian Coalition for Global Health Research, the Medical Council of Canada, and the Canadian Society for International Health, where he and I have been working together over the past few years. He is passionate about health equity, community engaged initiatives, and health advocacy work. So you can see how he nicely fits into the panel from our earlier conversations. And in these interesting times, global health will attract more trainees to disciplines such as public health, epidemiology, infectious diseases, and of course, health geography. The pandemic emphasizes why it is important to train all students as global citizens. So it's only fitting to have Dr. Yipeng speak about the challenges and opportunities this moment presents for those undergoing medical training. I'm going to hand the virtual floor to you, Dr. Yipeng.
Thank you so very much for the very warm introductions. I'm really excited to be here with everyone today, and it's been really interesting to learn more from the other two presenters, and I look forward to our fourth presenter after myself. I want to start off by acknowledging, you can probably tell by the background, I'm in the lobby of the Ottawa Hospital, the general campus. The clinical day ran a bit long and I wasn't able to race home to unmask and change and shower to be here with you all, but I'm glad to be here regardless. I want to acknowledge that I'm on the land of the traditional territory of the Algonquin people, the unceded, unsurrendered traditional territory. the Algonquin people, the place where I get to have the privilege of learning, working, and playing. As Shauna mentioned, I come from a few different lenses in how I wanted to kind of tackle this particular question of impact to those that are going through medical training. So I kind of thought about how to approach this question in terms of, maybe more of a structured framework, because we know that there have been certain disproportionate impacts to how those that are going through medical training in their undergraduate medical education years, such as medical students, as well as those that are in their postgraduate medical education years, such as myself in residency training. And so I've had a unique opportunity to be in both, positions as the COVID-19 pandemic escalated in our communities back in mid-March when I was still a medical student. And now I have the privilege of having some clinical duties and responsibilities, as well as some public health related duties and responsibilities. I would be remiss to not also mention, I think, all of my colleagues who are doing both public health and clinical medicine one-on-one patient care work during this pandemic. I think one of the biggest things I've come to realize, as many of my colleagues have, especially everyone else too on this call and discussion, is how to keep oneself well during such drastic changes to our lives, drastic changes to how we work and how we communicate and connect, such as this space here. But knowing that there's also been so much suffering, including the loss of life to those in the medical profession and otherwise. So I do want to acknowledge that piece. So in terms of some of the challenges that I wanted to, I think, highlight impacted those that are going through medical training are obviously disruptions to training and learning opportunities. One of the biggest things has been redeployment of trainees and how to think about maintaining and getting those really important competencies of a graduating physician that they feel comfortable and ready to be independently practicing when we see in-person clinics, especially in community settings, in urban settings, be more less accessible, essentially, because of public health restrictions and recommendations, as well as safety around PPE supply. One of the things that has been ongoing for all healthcare personnel, but is really important in the context of those that are still training and taking off some of those training wheels in terms of how we understand the knowledge base of working in such a fast-paced and changing environment. We know that the way that we communicate, the way that we connect has changed in terms of interviews for how medical students are getting exposure to residency programs, as well as the cancellation of visiting electives for medical students across the country. One of the unique aspects of medical education and training in Canada, and I believe in many parts of the world, is students and trainees doing rotations in different hospitals and different environments to gain various exposures about how different systems work, different specialties of medicine and practice work. But that has certainly been limited because of the public health recommendations and mandates in the current context. As well as there have been lots of discussions over these past few months and continually in the months ahead around challenges to licensing, challenges to examinations, and how do we move some of those things into a virtual setting, especially when some of those examinations were originally done in person with a standardized patient to simulate a clinical interaction, and how to change some of those pieces into a virtual setting is certainly a challenge. There are many opportunities too, I think. I think with learning from all of my different colleagues that have gone through these drastic changes to our lives, our education, our ways of working. There are many different silver linings that we can pick and pull from that training experience, including learning more about virtual care and how to use this modality to continue and provide quality care for patients that need it the most in the context of, say, mental health or otherwise. These are some unique opportunities to build off of, because we know that virtual care is certainly not going away, as we've seen really great benefits in continuity care, especially in the primary care setting, as well as for teaching and learning. How do we do that in a virtual setting has certainly been a challenge, not only for medical students and residents, but students and young professionals at large, and how to support students, how to support educators through this very drastic transition of a new way of learning and connecting. As well, I think there has been a really interesting spotlight on how public health physicians do their work and protect, promote the health of the community. And I think more colleagues and more trainees in the medical field are learning more about what public health and preventive medicine physicians and residents do to tackle and respond and recover from the COVID-19 pandemic. And the last piece in terms of opportunities, I would say there has been, increasing ways of collaborating, of meeting. We have people, to my understanding, in many different parts of the world on this particular discussion. So I think we've really increased that piece around accessibility and equity in terms of how we connect. But there are certainly challenges in thinking about stable Wi-Fi connection, access to technologies that allow for us to do these ways of connecting. The other thing that I think I wanted to highlight is the role of learners in this pandemic response. I've had an opportunity to connect with lots of different students and residents across the country in the context of being the youth delegate for the World Health Assembly and the Pan American Health Organization. And one of the really unique ways that learners, medical learners, but students across the country have been contributing is through doing essential work, such as working in a clinical context and taking care of patients, but also being a part of the public health response through doing contact tracing, through doing case management work with our public health nurses at local and various provincial, federal, territorial, and international public health contexts. As well as this was a piece that happened perhaps a few months ago now, when our medical students and residents across the country had a bit more time off, and things were a bit more uncertain with how long things would last, but there were many that were contributing to volunteering to support childcare for those frontline workers that needed support with their young ones at home, as well as PPE donation drives, 3D printing initiatives to think about how do we create masks and visors that are recyclable, that are accessible, thinking about the shortages that happened over these past few months and continue to be a big topic of concern, as well as hospital screening, being at the greeting greeting staff entering a hospital or a clinic and screening some of those pieces. But I would also be remiss to not mention that there's this piece around pandemic productivity. I think over these past few months, it feels like it's kind of gone by in the blink of an eye, but it also has felt like an eternity. And in these periods of times, I think it's been challenging to say the least, in terms of how do we work in this new environment, but also how do we stay productive and And can we allow ourselves to give ourselves the kindness and the compassion to draw back on making sure that we're checking in with ourselves, making sure that we're checking in with our feelings or emotions, especially around grief in such a changing context, and being okay with drawing back on that productivity piece, recognizing that some aspects of our society, of the way that our structures and our world has been built, has led to some of these crippling impacts of the current pandemic, perhaps because we didn't prioritize or incentivize things to put health and well-being and community building at the highest priority, and looked at other things like productivity or economic growth. The other thing that I'll quickly comment on, because of my role in learning from Canadian youth across the country for the purposes of collaborating with the Public Health Agency of Canada and the Office of International Affairs in part of the Canadian delegation to the World Health Assembly and the Pan American Health Organization Directing Council, is learning about the youth of the COVID-19 pandemic. And I think I've touched on some of those pieces that have uniquely impacted those that are going through medical or public health training. But knowing that youth is a very diverse identity, and that things like disruptions to education, challenges to mental wellness, as well as challenges to finances, employment opportunities, volunteering opportunities. I think one of the things that stuck out to me the most as I learned from Canadian youth across the country was that with this change to how we socialize, the changes and disruptions to job opportunities, these are crucial years for how young people see themselves and develop their own identities in this world, and how they see themselves in this world, but also where they see their role in society. And with all of these challenges to job opportunities, to volunteering opportunities, and this drive for pandemic productivity, and perhaps a lack of mentorship opportunities, I'm really scared to think about those disastrous impacts on how are we best supporting our future and current leaders that are still in their formal training years, whether it be in elementary school, high school, postgraduate education, and so on. And the other piece there I would want to mention is through social determinants of health lens, many youth across the country have recognized that they feel very privileged to be able to have a roof over their head, food on the table, and have some of those determinants of health be available to them, and recognizing that not every youth is in such a position to be thankful for, and those are the individuals that we hear less from because of the challenges of the disproportionate impacts of the pandemic on the most vulnerable and the most vulnerable youth. So I think there are really unique ways for how youth can come to the table to assist to COVID-19, and that is through communications to tackle misinformation, tackle the infodemic, through advocacy on these really crucial pieces of health and social inequity, and the concurrent syndemics of climate, racism, and mental health, housing, opioids crisis, as well as how do we think about youth and youth voices in that decision-making process and different governance structures, and sharing some of these best practices as youth have really mobilized, students have mobilized to fill some of those gaps that previously were there, and moving forward on how do we keep those initiatives sustainable. And the last thing that I'll just mention is I think there's a really opportunity, I guess, really important opportunity here to educate for prevention. Let's educate the youth of today and for tomorrow to think about the culture of prevention, being proactive, and to be prepared. There's this paradox of prevention that we all know, I think, that has led us to repeat history today in terms of this not being the first pandemic, this not being the first epidemic that we will go through as a community, as a world, but how do we actually break that cycle of forgetting these really important lessons in history so that we can build those infrastructures that really prioritize health and well-being. I'll end it there. Thanks, Jonathan.
Thank you very much, Dr. Yiping. It's always important to have both the voice of the experience of youth, and I think your point around diversity of youth identity is a really important conversation that we can explore a little bit further. And I liked your link from health promotion. I'm sure Dr. Foreman is nodding her head from her earlier comments as well, as she took us through the importance of thinking about the growth of global health and health for all in and of itself. So thank you very much. We're going to move on to Dr. Yap Boom, who is joining us this evening as well. He's the current epicenter representative for Africa, which is the research arm of Médecins Sans Frontières, and also the former director of the epicenter at Mbarara Research Center in Uganda. Dr. Boom has an engineering degree in quality management, a master's in microbiology, a master's in public health, and a PhD in biology. Impressive. For the last 10 years, he has led several research projects related to diseases affecting Africa, specifically malaria, tuberculosis, and HIV, which has generated more than 100 publications. He was recently coordinating the field activities of a phase 3 clinical trial of the vaccine against the Ebola virus disease in Guinea and the Democratic Republic of Congo. Dr. Boom is here today, and he'll speak about creating more equitable international partnerships and translating theory into action. So thank you for joining us, Dr. Boom, coming from Cameroon, I believe, tonight, this afternoon, this evening.
Actually, very early morning, because we are half past midnight here in Yaoundé. So thanks very much. We'll switch off the camera so that we have a better sound. Are you seeing my presentation yet?
Yes, I am. Yep, it's there.
Thank you. So decolonizing global health is definitely a just cause for all of us, but let me say more even for us as African. So the current state of global health, let me focus on research partnership, is that almost all the research agenda, the writing, the grants, the money, and all that is coming from the North, while the global South happened to be there to collect data. I remember my first conference was in Tanzania, and then there's that guy who was telling that the Western people have the money, and then we do have the patient. So that's how he was looking at the global health, as us being provider of blood, of patient, and sample. And then I've been interested on figuring out where the African researchers was fitting in all what was happening in Africa. And then when you look at those two papers that we've been working on, the first one is Stuck in the Middle, and the second one is Who's Telling the Story, is actually simply showing how African researchers are not actually leading or recognized for the research that is happening in Africa. That's important to mention. When you look at the publication in the first article, working with top universities such as Harvard, Yale, and so on, as an African researcher, you were less likely to be first or last authors. And then when we were looking at Who's Telling the Story, looking at 6 infectious disease, Ebola, HIV, TB, malaria, still you were realizing that almost 30 to 40% of all the publication were having an African as first or last author. And we all know the one who is reading, the one who is signing the paper is actually the one who is telling his or her story. So now let's go back to COVID-19. And then one of the breakthrough during the COVID is the story of chloroquine. And then you can see Trump on one side, what was mentioned that he has been using it, but all that coming from Professor Raoult, who has been quite involved in working in Senegal, which is in West Africa. And since Professor Raoult has actually say and advocate for the use of chloroquine, most African countries, without any evidence from research, has been implementing it as part of their national guideline. So even if now quite a number of papers are saying that it's not working, we are still using it. So we are still back in a time where we consider the truth coming from the north. Now, the second thing that I would like to talk about is the vaccine. I mean, the discussion, the conversation about Africa having access to the vaccine, this initiative from WHO with the COVAX, it is quite interesting. So the question is where Africa fits in the COVID vaccine. When you look at the research pipeline, there are, I don't know, 100 clinical trials globally. And you will see 2, 3 maybe that are happening in Africa. That's one. And how many of those vaccines are actually coming from Africa in the sense that African researchers have been working on that, not only implementing the trial, but actually also designing the trial and then even looking for the different molecules. Almost none. So eventually this is also showing how we fit just at the end of the continuum. But there's some hope. This is an evaluation that we did on the rapid diagnostic test. We started sometime back in June of this year, while the COVID was going on. I won't go into the detail. We were just evaluating antigen and antibody tests for COVID. And then we realized that the antigen was having a good performance, 75% of sensitivity, which for us was quite important because despite the Western, and let me say the WHO, going against saying that you can use a test only if you have a sensitivity of 95%. And then we were like, okay, we don't have that, but we have our patients who are in our community, the PCR, the molecular test, that is the one recommended. We have 15 labs who are able to run it in the country, but this cannot be present everywhere. So we had to find our own solution. And then we decided to roll out based on those, what we call positive results. We decided our own algorithm using the rapid test and the PCR depending on the result. And then our scientific committee, that was in July, actually validated the use of those tests in July. And then since then, we've been used 500,000 of those antigen tests, and then to have more than 8,000 positive, which for our country was like 4 out of 10 positive case captured using those tests. I'm showing that example because that is something that was done against what the scientific community, the Western community was actually appreciating. But now, let's go back to where we are now. In September, you have all those articles and the WHO and the European Union now investing on buying those tests that were considered not working well because of the performance, but eventually going back to that. So this is an example of how we are moving toward decolonizing by focusing on finding the solution for the challenge that we face based on our own standard. In that example, the standard, the common standard of sensitivity or specificity were not matching or responding to our challenges. This COVID is definitely an opportunity. Most of the time after a shock, we think about resilience. Resilience, which is mainly going back to where you were before the shock. But I prefer the kintsugi, which is a Japanese concept, where actually after the shock, you actually become much better than where you were before. So how do we do that? We need to have the funding that should go directly to the Global South. And then we wrote a paper some time back with the highlighting that when the money has to go first to a Western university or institution before going to the South, then there is already some gap in what will eventually reach the global south. So David, that what we need to advocate, I'm happy to have all this panel and all those, all of you, to realize that one thing we need to do is actually fund directly to the global south. The second thing is it has to be a two-way. Decolonizing, it's not something that will come from the north only, because if that's the case, then again, it will be neo-colonialism, as been mentioned earlier. It also needs to have a strong leadership from the global south, a strong leadership both in terms of communication, in terms of mentorship, in terms of giving the direction. As I gave the example of the rapid test, we need to decide what we need for us, and if need, requires some support, and that support will be part of open discussion on what is needed from our side and what our partner from the West can actually bring on the table. So we have a role, we definitely have the role, and one thing that is critical is the money. If the fund is coming always from the north, the one who has the money is usually the one who dictates. My father used to tell me that the hand that is asking is the one that is on the bottom. So if you are asking, it seems that you are begging. But if we manage to mobilize our own funding, then the power, the dynamic will change. Second thing that we have not been tapping on enough, according to me, and I hope that we have some African part of the discussion, is the diaspora. A lot of Africans are present in the north and in different places, good university, good institution. We definitely need to tap more on that diaspora to come and support, invest, and ensure that global health after this COVID is becoming something else. The only fact that currently we have more than 100 people attending this meeting by just, in bracket, having an internet connection is already something great. And then this is beyond resilience, it's actually going to Kintsugi, because then now we have more people that we can reach. So that's also one example. How can we keep with that pace? And the diaspora, who is all over the world from Africa, should be one of the key leaders of the change that we want to see in the continent. What do we expect? We are not talking about equality. We are definitely talking about equity. And I really like that cartoon where you see that small kids. If they were all given the same table, then these kids will not see the game. We definitely have to consider equity. What do we mean? Equity for researcher in the research agenda. The only way to ensure that the research that we are doing, the global health that we are doing, makes sense for the community is to ensure that the community is part, in one way or the other, to the agenda. Equity knowledge acquisition. If all the paper that we are publishing are in high impact factor journal that are not available or accessible because of the cost, the fees, and so on, then we are not making impact in the or on the people that we want to target. Same thing for the publication, the career development, and of course the partnership. I will come to that a bit later. The community is key. Even if you look at what is happening currently in COVID in the north and in the south, the country where it's more challenging to control the pandemic is actually the country where the community has not been that well engaged. So we need to make sure, and this is an inheritage learning that we've got from Ebola in DRC, in Guinea, in all those countries. We need to have the community that is part of the solution, not only part of the problem. That's the only way that we know to be able to come and to fight pandemic like the COVID. So to conclude, I will say, to move toward equitable global health, what we need is actually all of us to do something. We are around 100 people listening to this very interesting panel. Beyond that, what will we be doing? Some of us will be writing, will be attending to panel. Others can fund, others can support, connect, but at any point, every single person who is listening this panel should ask his or herself, what is there I can do to contribute to decolonizing global health? As for us, we will devote our blood, sweat, and tears to this just cause. Thank you.
Thank you, Dr. Boom. I think that was a wonderful conclusion to our panel, in which you gave some very strong local examples of the importance of engaging with community and the strength, resilience within the work that you're doing. And I like your ending. It was going to be one of my questions of what do we do next is one of the important questions that we do need to explore. So thank you for helping to round off this wonderful discussion. We have some time for discussion, and maybe I'll get the four panelists to join us virtually with their screens. And one thing I may do first is to see if each of you, if any of you have a question that, because you've been listening as well, so if you have a question that you wanted to explore with the panel before I start and dig into some of mine, happy to open up to the four of you.
I can share a quick reflection. I think I really appreciated reading Canada's Chief Public Health Officer's annual report on the inequitable and disproportionate impacts of the COVID-19 pandemic on vulnerable populations, and the intersectional identity piece of how you know, we're all impacted, but we're all impacted differently, and how to tackle that. And I think this is a really nice space to reflect on that conversation. I'm really glad that you highlighted that, Lisa. But I'm curious, you know, how do we actually put that report into action, perhaps? Because just reading through it, I was like, you know, heavily nodding every paragraph and every kind of subheading, but it's about putting some of those things into action through policy, through programming, and through some of these really complex structures that haven't allowed for vulnerable groups and populations to really succeed. So I guess more of a reflection, but I'm really curious to hear others' comments on that.
Well, thanks for that fantastic question, and also I just want to thank you, Yuping and Yap and Renzo. That was an incredible panel. I was writing furiously through each one of your presentations, and there's a lot of the citations and the ideas that I'm going to be following up on. So, I mean, I think, Yuping, that's such a fantastic question. And I feel like this kind of weird controversy that we had around a reluctance to gather data on race inequities in Toronto is a really interesting piece of this, because you know, it's one thing to say at the sort of, you know, we have sort of the Canadian Charter speaks very clearly about the imperative of non-discrimination, and Canada, like, you know, most other sort of global states, is signed onto all of the human rights treaties. And, you know, we have the laws, we have the policies, we have the language at all the levels. But then if you're not connecting this with a real willingness to gather the data, gather the evidence to see how these disparities are happening, then there's this tremendous disconnect. And, you know, and the fact that we saw this, you know, similar controversies around data being censored, around racial disparities in COVID happening in the UK, I think kind of tells you about the resistance there's this disjuncture between the rhetoric and the practice. And, this is where I think that, researchers have such an important role to play. I mean, I my incredible colleagues at the Dalhousie School, Arjuman Siddiqui and others, were really, really instrumental and effective in pushing for that data to be collected. And so there's this way in which, research and policy and rhetoric and evidence can come together. And it has to come together if we're going to take it seriously and do something.
Yep, I'll jump in. First and foremost, it was a pleasure listening to all of you, my fellow panelists. The situationer that Lisa provided, Yap's examples as well. It's just amazing to be hearing all of you. Just a second. And I think, and then of course, Yipeng's, trying to bring it at the level of the frontliner, the clinical, because every time we talk about decolonizing and, changing global health, we always think of the macro, and really change has to happen at all levels. And so I think this entire group kind of gave the panoply of things to do. And, Dalhousie global health community has a big task on your plate now. And I think you are best positioned to, lead this revolution or transformation. But it also, I think several of us have already invoked on this. We need to work together. We need to build these enduring alliances that bring together North and South, even people within the same country. Canada is a country with a long history of, tension and interaction, between, the colonizer and the indigenous communities. And so that will need to be confronted as well. And then now you have new people coming in. Well, not new, because, Canada is a country of migration in itself. And so, with all these new people or people from outside that are, joining your society, all these challenges will need to be addressed. And finally, I like Yap's, one of his slides, he was saying we need equity in research, equity in policy making, equity in leadership. And that is somehow how I'm actually interpreting decolonizing global health. There's so many definitions, there's so many, ways of looking at it. And for me, I think that's the beauty of decolonizing. Let 1,000 flowers bloom and see how we can really enrich the conversation. But I think it's high time to practice what we preach. In global health, we always talk about equity in outcomes, in maternal health, in non-communicable disease, in HIV/AIDS treatment access. But now there should be equity, not just in outcomes, but in the operations of global health. Yeah, and so this is the way I interpret it. And so COVID-19 has upended global health, and that it's actually a window of opportunity for change. When there's disruption, that's actually an opportunity for reset. And so that's my remark.
Shauna, I think you're on mute.
I am. Sorry about that. I wanted to draw on one point that also came across each of your presentations, which was around the piece around community engagement. You may have named it differently, but it was in there in each one. So I think, Renzo, as you were just speaking and thinking about equity and that disruption, a lot of us have talked about this for many years, of the importance of hearing the voices of community and having that really influence the work that we do. But the talk and the practice don't often match, right? So when you spoke of that, Yap, I just kept, you articulated it so nicely, but it was in each person's presentation in different ways. I think that's the piece that we struggle with, because that is where power is going to be also disrupted? Are we truly willing to listen to community? And if we do, it means we need to do something with that information, and change is there, and that's unsettling for us. But I think, yeah, go ahead, Renzo.
Well, very quickly, and just a quick story. So my doctoral dissertation is a two-part dissertation. It has a 200-page write-up that only 3 people read. That's my committee. And short films that actually capture the voices of the communities that I hesitate to say studied, I actually work with them. And so, even in our research methods, we need to start thinking, how can we make sure we go beyond, commodifying or instrumentalizing, our subject, even in the way we describe them, right? We're jumping to the field to collect data, bring back to the university, and then process it using in vivo, right? And Stata. And so, we need a lot, there's a need to really shake things up in research, in our vocabulary, in our methodology, in the way we present research. And so, that 200-page dissertation, I have to still resurrect it and turn it into, publications. But my films had been viewed by tens of thousands of people. And so, and I'm not the one narrating the challenges that they're confronting. They are the ones telling it in front of the camera. And so, that's just one example. I think, our audience might be asking, what are the concrete solutions? These are really great, aspirations, ideals, but how do we translate it? That's one of the ways. I'm sure there are more.
Mm-hmm. Yeah.
Yes. Maybe if there is one thing that I can add, and I was really enjoying all the presentation, and about the community and about all what we are doing, the question we are asking ourselves is, who do we want to impact? Is if we want to impact ourselves, definitely what we need to do is to publish our research in those school journals, which we do. But if we want to impact the community, we need to send a message where they actually are. And I'm happy about what Renzo was just talking about, making a video that will be watched by thousands of people. That's actually eventually what really matters, because that's where the community will understand what we are actually saying. And then we need to translate our messages, because what you write in the Lancet is accessible to 1% of the population. 1%, sometimes it's even a lot. But how do we get in the social media with trying to shorten all your 200 pages in 50 words, even less? I don't know how many words you can put in Twitter. So this is definitely a challenge that we have to achieve, to make sure that the community is definitely the one we really want to impact.
Yeah, and I would pull out from one of Lisa's comments, which you just touched on at the end. You said something about the institutions in which we work as well, and the post-secondary education institutes. So for each of these comments about research, I think one of our biggest challenges and our research and the relationship with communities is how we are measured within our academic institutions, right? And so I think some of that is starting to change for sure. But when I think about what we need to do is we need to keep questioning, what is that measurement of success? And we all have faculty members and colleagues who do wonderful community-based work, who are having a hard time in their promotion and tenure because that's not valued in the same way as publications in high-impact journals. Oh, Renzo.
Yeah. Very quickly, because you mentioned the phrase measure of success. I was just in a meeting yesterday with a funder, and they're asking me, Dr. Renzo, if we are going to reshape our funding strategy, how should we do it? And I told them that, you should be investing in the next cadre of global health researchers from the South, in order to cut this dependence on northern universities jumping to, doing safari research, right? Collecting this data, publishing, the problems that Yap was raising a while ago. And so, we've seen a lot of these, capacity building programs that really did not build capacity, but instead led to publications that promoted our faculty friends from, the North. I think there is also a need to change the incentive system. So how can universities incentivize? I would love, professors to be measured not just in terms of their publications, but also did they actually build capacity in this low income setting so that they can generate, evidence that responds to their local needs.
Mm-hmm. Yeah, exactly. And Yiping, I see you're talking about TikTok as a platform, and yes, there's lots of great KT knowledge translation work that's happening through that platform. So I'm really quite sad because we are at time, and I know that there's lots that we could be both exploring through these conversations as a panel and with our guests, but I also want to be respectful of time, especially for those that are late at night and early in the morning, and for dear Yiping, who probably wants to get home eventually. And so, but I genuinely want to thank each of you for the time, the thoughtfulness, the engaging discussion. And I do believe that this is the beginning of some very exciting conversations. And Renzo, you keep saying Dalhousie's mission. And yes, we are looking at what this looks like for Dalhousie, but this is a collective conversation with the broader community of people who are engaged in all things that are related to global health. And however we define that, I think we have some principles and values that we collectively believe and would agree to as a community. So I do look forward to working with all of you in the future, and I thank you. I wish you safe journeys home for those that aren't home yet, and generally safety and good health and well-being until we meet again. And thank you to all of you for joining us over this last hour and a half. We will be in touch with a survey and some questions so that we can determine some of our next steps and action deliverables as we move forward. So thank you once again to all of you.
Thank you.
Thank you very much.
Bye.
Thank
Bye-bye.
you.
Thank you.
Bye now.
Bye.
Stay safe, everyone. Thank you.
Bye-bye.
Have some coffee, Renzo.
Done. Take care. Bye-bye, Shauna.
Bye now.
Thank you. Keep in touch.